Hi, good afternoon, everyone. I'm Dr. Anamika Bakliwal. I'm a practicing clinical hemat-oncologist from Delhi. And today I'm going to talk about anemia. So today's topic of discussion is clinical approach to anemia. As you can see in the first slide, how does a normal RBC looks like with a normal amount of red blood cell, while how does an anemic amount of red blood cell looks like. There's a huge difference that you can make out. Now, what is anemia? So, anemia is a condition in which the oxygen carrying capacity of the blood is decreased due to low hemoglobin levels, as a result of which body tissues do not get enough oxygen. Now, according to the National Family Health Survey, which was done between 2019 to 2022, women between 15 to 49 years suffer from 57%. 57% women suffer from iron deficiency anemia, but children constitute the maximum population who suffer from iron deficiency anemia, which is around 67%. And the other affected groups are adolescent girls, pregnant women, and adult men. So the government of India has initiated an intensive program to counteract the rising incidence and prevalence of anemia in India, which is called as Anemia Mukt Bharat, which is supporting this initiative. Here is an overview to understand anemia, its causes, symptoms, and complications. Now, since it's a 30-minute CME, I would like to mention that covering all anemias would not be possible here. So I'm going to talk about anemias which are the most common and the most prevalent one in our societies, starting with iron deficiency anemia. Now, what are the main causes of anemia in children and adults in India? So iron deficiency anemia certainly tops the list, followed by vitamin B12 deficiency and folate deficiency and anemia of chronic disease. The others are hemolytic anemia and aplastic anemia, commonly seen in children and adolescents. Now, what are some of the common effects and symptoms that one sees in the OPD when you are examining a patient of anemia? Patient can complain of fatigue, shortness of breath, lightheadedness, headache, palpitations, chest pain, rapid heartbeat, as I mentioned, palpitations, difficult in concentration. So there can be varied signs and symptoms. In severe cases, anemia can also lead to complications such as heart failure, stroke, and death if not addressed at the right time. Now, iron deficiency anemia. It affects 1.2 billion individuals worldwide and most commonly seen in children, adolescents, young women, and pregnant women, as I spoke about it earlier. Now, epidemiology. Now, as per the WHO recommended cutoff, any male with a hemoglobin of 13 gram per DL, any female with a hemoglobin of 12 gram per DL, and any female with a hemoglobin of 11 gram per DL during pregnancy is defined as anemia. Now, this is an iron absorption pathway. I'm not going to go into too much detail. This is just a diagram representing how an iron absorption pathway works. One just needs to remember that duodenum forms the mainstay where the iron absorption works or happens. Now, coming to pathogenesis of iron deficiency anemia. Obviously, we are talking about iron deficiency anemia. So we also, as general physicians and students, need to know that what are the causes which cause iron deficiency anemia. So anyone with increased iron requirement, for who are those, what constitutes of people who require increased iron requirement? So infants, preschool children, adolescent, pregnant women, especially in their second and third trimester, anybody who takes low iron intake. Now, what kind of people you would assume are taking low iron intake? Especially people who are vegans, vegetarians, and malnutrition, which is protein energy malnutrition, where insufficient dietary iron like low heme iron or scarcely available bioavailable iron. Now, decreased intestinal iron absorption, where a person has undergone a gastrectomy, a duodenal bypass, or anybody with an H. pylori infection, anybody who's taking proton pump inhibitors for a very prolonged time. Now, the last, but like very important ones, anybody with chronic blood loss. Now, who are the people who suffer from chronic blood loss? Anybody with hookworm infestation, anybody consuming salicylates, corticosteroids, and NSAIDs for a very prolonged time, people with heavy menses, drugs like anticoagulants and antiplatelet compounds, and frequent blood donors. Now, what are the other miscellaneous causes? Anybody with chronic infections, chronic cystic kidney disease, chronic liver disease, systolic heart failure, and inflammatory bowel diseases. So basically, it is divided into 5 broad categories where anybody who requires increased iron can suffer from increased iron deficiency anemia, where their demands are not being met. Anybody with low iron intake, anybody with decreased intestinal iron absorption, anyone with chronic blood loss, and other multiple causes as I discussed. Now, in this slide, you can see what are the common features by which I mean common signs and symptoms. So fatigue, restless leg syndrome. Yes, restless leg syndrome is a very, very common scenario that we get to see in our OPD. One must certainly take a good crisp history and elicit all the signs and symptoms of the patient in order to come to a diagnosis of iron deficiency anemia. Now, restless leg syndrome is nothing but night cramps and leg cramps which enable the patient to sleep at night. And this is a typical history. If you take a good history, the female or the male suffering from iron deficiency anemia, especially females, will certainly give you this history if they are suffering from severe iron deficiency anemia. Anybody on physical examination, you are going to see angular cheilitis and aphthous ulcer. Again, history of pica is extremely important. Anybody consuming excessive amount of ice, anybody consuming excessive amount of chalk, sand, paper, these histories are important clues which direct us towards iron deficiency anemia. So as you can see, these are the different clinical findings. The first slide shows aphthous ulcers, second one is pica, then spoon-shaped nails, restless leg syndrome, angular cheilitis. So nothing can beat a good physical examination and a good clinical history. Now, this is a case scenario which we encountered when I was practicing as a DMSR. So this was a 52-year-old woman who presented to us with abdominal pain, dysphagia, and fatigue. And her previous records showed that she had gastric adenocarcinoma and she was treated with chemotherapy 6 years back, along with a surgery, which was a gastroduodenectomy that she underwent for the same. Now, when she presented to us, since she had severe abdominal pain and dysphagia fatigue, she underwent a CT angiography, and which revealed a thrombus in the abdominal aorta, but there was no organomegaly. So the lab findings were suggestive of hemoglobin 7 gram per DL. MCV was 61. She had severe thrombocytosis, which was a platelet count of 7.50 lakh. There was reticulocytosis was 2.5% and serum ferritin of 6 nanogram per m. Peripheral smear showed thrombocytosis, hypochromia, and anisopoikilocytosis. Now you can see here that the upper endoscopy when done demonstrated some typical upper esophageal webs, which were nothing but the webs that you can see in this particular picture. So I really don't know how many of you can think of the actual diagnosis. Well, I'll tell you the actual diagnosis. It was a Plummer-Vinson syndrome and reactive thrombocytosis masking a JAK2V617F positive myeloproliferative neoplasm. So this was rather a very, very rare clinical scenario where a patient of myeloproliferative neoplasm presented with thrombocytosis, which they do. And along with that, there was Plummer-Vinson syndrome, which is demonstrated very beautifully here by an upper endoscopy, which was done. You can see an upper esophageal web. So yeah, so this was a rare case scenario. Now coming to the next scenario, this was a simple, straightforward case where a 62-year-old male patient with history of severe constipation, breathlessness, and fatigue came to me in the OPD. Now, history of constipation is extremely important, especially in elderly men and women. We tend to ignore it in the OPD. But when you go into details, you will realize that the constipation is genuinely very severe and chronic. And we need to also direct them to a good gastroenterologist who would further evaluate the person in terms of doing a colonoscopy or a upper GI scopy, because the root cause of iron deficiency anemia, I'm emphasizing again, the root cause of iron deficiency anemia needs to be addressed. Unless you address the root cause, whether it's a heavy menstrual bleed, whether it's a polyp, duodenal polyp, jejunal polyp, any kind of polyp, Well, you can give treatment for iron deficiency anemia, but unless you eradicate the root cause, the problem will keep erupting again and again and it will form a vicious cycle. So in this case, the man told me that he has been to so many doctors and, has had this problem, but nobody really, they did give him iron supplementation, but it still continues to happen. So I asked a dear friend who's a gastroenterologist, and he did a per rectal examination. He was a GI surgeon, and so it was suggestive of severe hemorrhoids. Further, a colonoscopy was done, which was suggestive of multiple polyps. Lab findings showed a hemoglobin of 7 and an MCV of 61. Drug history was very significant since the patient was on ecosprin since 20 years for diabetes, and also he was taking proton pump inhibitors on and off since quite a number of years. So this is how his peripheral smear looked like, where you can see a classic iron deficiency anemia with a microcytic hypochromic anemic picture and severe anisopoikilocytosis with teardrop cells. So yeah, this is a classical peripheral smear of iron deficiency anemia. I treated him with IV iron. He obviously started feeling much better after receiving IV iron. But here I would like to mention that since the root cause was identified, the problem did not come back and the patient was doing fine. Similarly, also, I haven't mentioned about that case scenario, but I would like to mention many females come to us in the OPD, especially between the age of 15 to 35. And then they mention about fatigue and breathlessness. When we do a serum ferritin, it is extremely low. Their MCV is extremely low. Their hemoglobin param is extremely low. And please take a good menstrual history. It is extremely important. They themselves are not able to identify whether their menstrual cycle is regular or irregular, and they need to be directed to a good gynecologist in order to find out whether an ultrasound, whole abdomen, or any of such investigation is further required to find out the root cause of that heavy menstrual bleeding. Because again, as I said, we can obviously give treatment in form of oral and iron formulations, but root cause needs to be eradicated. So the three commonest scenarios that I've encountered in my OPD practice is first, a heavy menstrual bleeding women who comes with fatigue, breathlessness, and pallor. Then there are elderly men who come with severe constipation and hemorrhoids. And the third one being children who come to me with malnutrition and faulty dietary practices. So yeah, these are the three scenarios that one must keep in mind while treating iron deficiency anemia. Now, diagnosing iron deficiency anemia, this is my personal request. If any lab person or a pathologist is seeing this particular CME, I have come across this problem, and I'm sure my other colleagues will also agree that the serum iron profile, which is such an important iron parameter, I mean, they somehow don't mention about serum ferritin levels. While serum ferritin levels are the hallmark of absolute iron deficiency anemia, and they tell us that the iron stores are exhausted. So please try and incorporate serum ferritin along with serum iron profile. Getting a transparent, measuring TF saturation and hepcidin levels are unnecessary for a straightforward case of iron deficiency anemia. One must only and only think of a good CBC, a crisp peripheral smear, a retic count, and ferritin levels. That's it. Now, I've already shown you this peripheral smear examination in iron deficiency, where you can see red cells are profoundly hypochromic and microcytic, while there is also another finding where you can see increased platelets. Now, treatment, there are two kinds of treatment, oral iron and IV iron. Now, oral salts such as iron sulfate, fumarate, and gluconate remain a mainstay of therapy in absolute iron deficiency. Now, other common adverse effects such as nausea, vomiting, constipation, diarrhea are commonly seen with a patient who takes oral iron supplementation. So that's why it's very important to keep a check on their compliance, as most people leave taking oral iron because of these side effects. A prophylactic treatment with iron sulfate, 60 mg in adults and 30 mg in children, has been recommended. Now, what are the indications of IV iron therapy? Now, anybody with oral iron intolerance, like for example, I mentioned persistent gastrointestinal adverse effects, Anybody with oral iron refractoriness, where there is no hemoglobin improvement after 4 weeks of oral therapy, which could also be because of the poor compliance of the patient, because of the gastrointestinal side effects. Anybody who has undergone a duodenal bypass, a bariatric surgery with H. pylori infections, intestinal disorders, genetic forms, which is commonly known as IRIDA. So all those people will require IV iron therapy. Anybody who has severe anemia and presenting to the OPD with a hemoglobin of less than 7 to 8 gram per DL. People in their second and third trimester of pregnancy. Anybody on treatment consisting of erythropoietin stimulating agents for chronic cystic kidney disease. Chronic blood loss, which are difficult to manage with oral iron, like heavy uterine bleeding, and somebody with von Willebrand disorders, anybody with post-operative anemia of major surgery. Now, what are the types of safe IV iron formulations? Ferric carboxymaltose and iron isomaltoside. Now, dose usually is 1 to 1.5 grams in 1 or 2 infusions, which are given 2 weeks apart. Now, what is the advantage? Obviously, we can avoid repeated hospital visits. The recovery is really fast, especially if you're aiming to especially if one is aiming to rapidly increase hemoglobin in a pregnant woman, especially in her second and third trimester, or anybody with a heavy uterine bleeding, anybody with a single you'll only require a single access, then accelerated recovery and limited need for blood tests. Now, disadvantage, obviously, an important issue concerning IV iron is its safety, because iron is a growth factor for several pathogens, and iron therapy is contraindicated in infections. This, you must clearly remember, it is completely contraindicated in any kind of infection. And in some cases, some anaphylactic reactions with high molecular weight iron dextran is also seen. But in our OPD scenario, we commonly use ferric carboxymaltose, which is one of the safest iron IV formulation. Now, I'm going to talk about vitamin B12 deficiency, which is again a very, very common anemia. Vitamin B12 deficiency has many conspicuous hematological manifestations. Now, but one must also remember that it also presents with non-hematological complications, especially neurological complications like cognitive impairment, then other being neural tube defect in pregnancies, osteopenias, and vascular occlusive disorders. Now, pathobiology of vitamin B12 deficiency, it's in adult, the total body B12 store is 3 to 5 mg, and the recommended daily intake is 2.4 mg. Now, natural food sources of B12 are restricted to food of animal origin. That is why it is very, very commonly seen in vegetarians. It's a micronutrient that is often in critically short supply, as I mentioned, in vegetarians. Now, this is a slide which shows the absorption of vitamin B12. Well, I'm not going to go into detail of this slide. One must remember that it mostly occurs in the terminal ileum. Now, you can see this slide. We usually is a classical feature. If you see anybody with this sort of knuckle hyperpigmentation, one must certainly think of vitamin B12 deficiency. This is very commonly seen and is a classical sign of vitamin B. That's why physical examination in the OPD, in the IPD is extremely important. Now, diagnosis of vitamin B12 deficiency. What are the findings of CBC and peripheral blood smear? The anemia is macrocytic, where the mean corpuscular volume is 100 to 150 FL or more. Neutrophils typically show hypersegmentation of their nuclei beyond the usual 3 to 5 lobes and may contain 6 or more lobes. Patient may also present with leukopenia, thrombocytopenia. Now, this is a hypersegmented neutrophil where you can see neutrophils typically show hypersegmentation of the nuclei and they are containing more than 6 lobes. And this is how a photomicrograph of a bone marrow done in a patient with pernicious anemia looks like, where you can see megaloblastic change in the nucleus of an erythroid precursor. This is called as salt and pepper appearance. Now, I'll explain it with a scenario. So, 8-month-old female exclusively breastfed presented with pallor and a 2-month history of vomiting, diarrhea, and failure to thrive in my OPD. Her CBC showed an absolute neutropenia in the setting of normal white blood cell count, where her WBC was 5,300. Marked macrocytic anemia, where MCV was 110, HB was 6.5, and there was mild thrombocytopenia. So the differential diagnosis in my mind was nutritional deficiency, probably congenital bone marrow failure syndrome. But on examination, the child did not show any dysmorphic features. Probably some infection or some drug-induced bone marrow suppression or acute leukemia. And as MBBS students or even as general physicians, we must think of these differential diagnoses. Now, we're continuing the case scenario. The peripheral blood smear was remarkable for presence of macroovalocytes, as you can see in the first slide, microcytes, basophilic stippling, and rare hypersegmented neutrophil. The marrow was hypercellular with absolute erythroid hyperplasia, megaloblastic erythroid, and myeloid maturation. Dyserythropoiesis and dysgranulopoiesis was seen. An additional study showed a B12 was less than 30 picogram per ml. LDH was highly elevated, which was 2,274, and iron and folate studies were normal. So it was a clear-cut case of megaloblastic deficiency in a breastfeeding infant. Now, what are the causes of vitamin B12 deficiency? Severe deficiency and mild to moderate deficiency. So when do we see severe deficiency? Anybody with severe malabsorption, where there is deficiency of the anti-intrinsic factor antibody and anti-parietal cell antibody. Then pernicious anemia, total or partial gastrectomy, gastric bypass or other bariatric surgery, anybody who's undergone an ileal resection, any inherited disorders of vitamin B12 deficiency, inherited or metabolic disorders, impaired ability to transport B12, impaired ability to process B12, and mild to moderate deficiency is seen in vegetarians, anybody who's on prolonged use of a very commonly used drug like metformin, chronic pancreatic disease, etc., and infants and adults. Now, so what are the diagnoses? Continuing the diagnosis of vitamin B12 deficiency, obviously a good peripheral smear really helps. The other investigations of choice is retic count, vitamin B12 levels, elevated serum LDH levels. Sometimes because of hemolysis, there is indirect hyperbilirubinemia, and one must get an anti-parietal cell antibody and anti-intrinsic factor antibody. Now, concerning treatment of confirmed B12 deficiency, there are no clear-cut guidelines where the cause of the deficiency is not known or irreversible. Treatment must be lifelong. So whenever an patient of vitamin B12 deficiency presents with an anti-intrinsic factor antibody or anti-parietal cell antibody is present, the treatment is for lifelong. Otherwise, the choices lies between intramuscular injection of 1,000 microgram B12 given every other day for 1 to 2 weeks, followed by weekly injections for a month and then tapered to once a month. But indefinite injections should be given if a patient has anti-parietal cell antibody positivity and anti-intrinsic factor antibody positivity. Now, quickly talking about anemia of chronic disease, it constitutes 40% of anemia worldwide, and it's the second most common type of anemia worldwide. What is the etiology of anemia of chronic disease? That as general physicians, cardiologists, neurologists, we come across anybody with cancer and hematological malignancies, anybody suffering from prolonged ICU infections, immune-mediated disorders, inflammatory disorders, chronic cystic kidney disease, congestive heart failures, chronic liver disease, chronic pulmonary diseases, anemia of the elderly, obesity, and anemia of critical illness. I'm not going to really talk about this slide and not go into too much of detail regarding pathophysiology. Now, diagnostic algorithm, as you can see, females of hemoglobin less than 12 gram per DL for females and hemoglobin less than 13 gram for males. So no immediate action is required if we are considering anemia of chronic disease. Yes, evaluation is necessary. So we are going to look for the iron status. Now, SF less than 30 microgram per liter here and TSAT is less than 20%. Then you are going to consider iron deficiency and definitely refer this patient to gastroenterologist to rule out any malignancy. Now, if there is a clear-cut iron deficiency anemia kind of picture, then obviously you're going to give the patient oral iron in divided doses. IV iron certainly only and only has to be given if the patient does not have an underlying infection or an underlying inflammatory process. Now, where serum ferritin is between 30 to 100 microgram per liter and TSAT is less than 20%, again, we must rule out iron deficiency anemia. Now, where serum ferritin is more than 100 and TSAT is more than 20%, One must also get a serum creatinine and look for glomerular filtration rate. Why? Because we also need to consider chronic cystic kidney disease patients. Now, anybody with vitamin B12 or folic acid deficiency, if their levels are normal and if their levels are low. So if the levels are low, then obviously one must replace folic acid and vitamin B12 therapy, or else otherwise think of other hematological causes and refer the patient to a hematologist. Now, anemia in pediatric population and some interesting case scenarios. I'm going to quickly rush through 6 to 7 slides where we're going to talk about some interesting case scenarios and learn about anemia in pediatric population. Now, these are all cases from my OPD. So first case scenario was when a 1-year-old male child brought to me with chief complaint of loose motions, vomiting and fever with failure to thrive. So on inquiry, highly improper weaning only with diluted cow's milk was given. On examination, there was severe pallor and there was grade 4 PEM. There was no hepatosplenomegaly or any other significant findings. CBC showed a HB of 5.8 grams. MCV was 50.4, platelets of 2.45 lakh and WBC of 7,600. Retic count was 1%. PS showed pencil and teardrop cells. So it was a clear-cut case of iron deficiency anemia, and I put the child on oral iron at 6 milligram per kg per day of elemental ferrous salt. Retic count done on day 5 showed an oral iron after giving oral iron was 6%. So, and CBC repeated after 3 months showed a HB of 12.5 and other indices also returned to normal. Oral iron was continued for 3 months. This is how the peripheral smear looked like with a classical teardrop and pencil drop cells and a microcytic hypochromic picture. And diagnosis was nutritional deficiency anemia. Now, case scenario 2. There was a 2-year-old male child from Sindhi community presented with non-specific complaints of poor appetite and not thriving well. On examination, was averagely built and nourished, but had mild pallor. HB was 9.6. MCV was 54.2. PS showed a microcytic hypochromic picture with target cells and basophilic stippling. And HPLC showed a HbA of 2.9 and HbF of 80%. And this is exactly how the slide looked like. You can see the basophilic stippling and you can also appreciate target cells. So a diagnosis of homozygous beta thalassemia major was made. Now, case scenario 3, we've already spoken about the vitamin B12 deficiency where an exclusively breastfeeding infant came to me. So I'm going to quickly skip this and come to the next one. So case 4 was a 7.5-year-old female who was brought with chief complaint of developing reddish spots all over the body and bleeding gums and melena with a high-grade fever since last 2 days. So on examination, there was pallor, but classically, there was no lymphadenopathy, no bony tenderness or hepatosplenomegaly. So, well, why do I mention about this no lymphadenopathy, no bony tenderness and no hepatosplenomegaly? Because in my mind, I'm trying to rule out acute leukemia and think about other causes. So a bone marrow, first the CBC showed a HB of 7.5 and MCV 91. WBC count of 4,400 and a significantly reduced platelet count of 35,000 and retic count was 0.2%. PS showed normocytic anemia with few macrocytes, neutropenia and diminished platelet counts. This is how the bone marrow looked like, where the bone marrow aspiration and biopsy showed a hypocellular marrow with increased fat cells, megakaryocytes and markedly diminished. So a diagnosis of aplastic anemia was made. Now, case scenario 5, where a 6-year-old male child was admitted outside with history of fever and vomiting since last 10 days. He was referred to my OPD for increasing pallor and deteriorating renal functions. On examination, there was no lap, no organomegaly, significant pallor was present and other systems were normal. Now, this is how his labs looked like, where an MCV, where MCHC was 29, where the retic count was 9%, and LDH was 1,954. G6PD qualitative done was reduced, and PS showed an anisopoikilocytosis, polychromasia, and target cells. So this is how the peripheral smear looked like. You can see and appreciate the bite cells, half-eaten apple cells, and diagnosis of G6PD deficiency was made. Now, coming to the Second last case scenario, a 17-year-old male with history of 3 episodes of jaundice since 8 years of age with abdominal distension and a dragging abdominal pain. History of similar illness in one of his maternal uncles. On examination, there was significant pallor, icterus was present, spleen was 6 centimeters with no hepatomegaly. Now, CBC showed a HB of 10.8, an MCV of 76. Peripheral smear showed normocytic normochromic anemia. Now, indirect bilirubin was 4.14. Ultrasound showed splenomegaly. Osmotic fragility was increased and HPLC was normal. You can appreciate the spherocytes in the peripheral smear, and diagnosis of hereditary spherocytosis was made. Now, coming to the last case scenario, 8-year-old female child with history of multiple admissions for fever, pallor, and joint pain since 18 months of age. She received multiple blood transfusion which relieved her troubles. She was born of a consanguineous marriage and was from Hindu Maratha community, and she hailed from interiors of Maharashtra. On examination, there was mild pallor and icterus. CBC showed a HB of 9. Platelets 152, WBC 6,500, and PS showed sickle cells. And this is what the HPLC looked like. Sickle test was positive, HPF 21, HPS was 73.7. HPLC of father, mother, and younger brother revealed HBS heterozygous status. And this is the classical peripheral smear with sickle cells. And the child had sickle cell disease. So my take-home message would be, if anyone experiences the signs and symptoms like fatigue, breathlessness, leg cramps, increased facial pallor over a prolonged period of time, should not be ignored, and patients should try to reach to the doctor immediately. Please don't ignore these signs and symptoms. And treating underlying causes like hemorrhoids, heavy menstrual bleeding, and malnutrition is extremely important, as only giving iron supplementation is not enough. The root cause needs to be addressed. Physical examination and a good history still remains the golden key to the diagnosis of any case scenario. For example, classical signs like knuckle hyperpigmentation and vitamin B12 deficiency, absence of organomegaly and lymphadenopathy in aplastic anemia, splenomegaly and sickle cell disease, spoon-shaped nails, angular cheilitis, and IDA, etc. should not be missed. And a good peripheral smear is a must along with crisp interpretation of CBC. Thank you so much for your patience listening. So this